on covers. यह बोलने के बाद म्यूट कर लीजिएगा, हॉर्न का आवाज आ रहा है।
अच्छा।
Hello.
Yes, sir.
Hello.
Yes,
Good
sir.
afternoon.
Good afternoon, sir.
Good afternoon. Hi.
Good afternoon, sir.
Good afternoon.
How are you doing, sir?
Okay. चल रहा है. Okay.
Sir,
Soon,
may
I
I
think
start?
Abhishek, do we have all
Yeah.
the participants?
Yeah, we have all the 3 participants.
Okay. We have all the 3 participants, isn't it? So just give
Yes.
me a minute. I will be starting just in a minute.
Okay, sir.
Hello.
Yes, sir.
Yeah, I can start now.
Okay, Abhishek, go ahead.
Yeah. Good afternoon, everyone. Welcome to the case history presentation surgery event. We have with us our esteemed judge, Dr. Professor Ramanuj Mukherjee, MS, DNB, MNAMS, MRCS England, FMAS. He is a professor of surgery at Arjikar Medical College, Kolkata. He has been the assistant secretary of ASI from 2012 to 14 and joint secretary of ASI from 2016 to 18. Now I would like to invite Ayush Bhadani to talk something about sir.
Good morning, sir. Good afternoon, sir, and welcome to all the participants to this case history surgery presentations. Sir has been with us since our inception, and he has been the quiz master. He has been the judge for various of our events, and I am one of his lucky students. I'm one of the lucky students to have been taught by him. Sir is extremely famous in our student community because he is one of the best uh, teachers we have. He's extremely friendly and he can teach you in the best way possible. So we welcome you, sir. We welcome you on behalf of South Asian Medical Students Association. And sir, you can now start. Thank you.
Okay. Thank you, Yash, for the kind words. So let us start now. Okay. Right.
Okay, sir. The rules are
Hmm.
there will be a 5 minutes presentation followed by 10 minutes of cross questioning by our respected judge, Dr. Professor Ramanuj Mukherjee. Next, I would like to invite my co-host Nikita Prabhakar to start the event by introducing the first participant.
Good afternoon, everyone. Our first participant is Ishan Wazir from VMMC. His topic of presentation is inguinal swelling.
You may unmute Ishan.
Shall I start sharing my
Yeah.
screen?
Yeah, please start. Ishan, please start.
You have to give me the rights. It says host has disabled participant screen sharing. Please give me the rights.
Ayush, please allow him to share his screen.
Wait, yeah, I think you can share your screen now.
Is the screen visible?
Yes.
Great. Now?
Yes. You can start.
So, good afternoon to everyone. I am Ishan Wazir and I'm going to present a case on inguinal swelling. History. My patient is Manohar Lal, 49-year-old male, Hindu by religion and rickshaw puller by profession, and he resides at Kotla, Delhi. He presented to the OPD with the chief complaint of swelling in the left groin since 3 months. History of presenting illness. The patient was apparently well 3 months ago when he noticed a swelling in the left groin region. It was gradual in onset, progressed from a smaller size to the current size, aggravates on standing, walking, straining, and cycling, disappears on lying down on its own, accompanied by with a dragging sensation in the abdomen. There is no history suggestive of any raised abdominal pressure. No history of straining during maturation or any other dysuria, hesitation, urgency. No history of colicky abdominal pain, vomiting, or abdominal distension. And no history of any similar swelling on the opposite groin or anywhere else in the body. Past history, there is no history of any similar complaints in the past, no history of chronic diseases like diabetes, tuberculosis, or asthma, and no history of any trauma or abdominal or groin surgery. Personal history is a vegetarian with good appetite. He's smoking BD since the age of 25, that about 12 pack years. Normal bowel, bladder, and sleep habits. No history of alcohol consumption, and a patient is not diabetic or hypertensive. Belongs to lower middle class according to the modified Kupusomi scale. Family history, there is no history of diabetes, hypertension, or tuberculosis contact in family. No history of any connective tissue disorders. Treatment history, has not taken any treatment for present condition and no other ongoing medications are being taken. No history of allergy to any drug. History summary, my patient is Manohar Lal, 49-year-old gentleman hailing from Kotla, Delhi. He is a rickshaw puller by profession. He presented with a chief complaint of swelling in the left groin since 3 months, which aggravates on standing, walking, coughing, cycling, and disappears on lying down. It's probably suggestive of uncomplicated hernia. Examination. General examination, the patient is an elderly male, moderately built, cooperative, well oriented to time, place, and person. The examination is done in a well-lit room with full consent of the patient. He's comfortably seated and there are no signs of dehydration. Vitals, temperature 98.6, pulse 65 beats per minute, normal rate, rhythm, volume, character, BP 128 by 76 millimeter mercury, and respiratory rate 16 breaths per minute. Paralictor, sinus clubbing, lymphadenopathy, edema absent, BMI of 21.2 kg per meter square. Local examination, the patient is examined in a standing position, a proper consent is taken, and the patient is exposed from the xiphoid to the process to the mid thigh. On inspection, there is a 3 into 2 centimeter swelling in the left inguinal region. Swelling is pyriform in shape with a smooth surface and well-defined margins. It expands on coughing and reduces on lying down. There are no skin changes, visible pulsation, scarring, or dilated veins over the swelling. Surrounding area appears to be normal. Scrotal area also appears to be normal and free of any swelling. The right side is also normal. On palpation, all the inspectory findings were confirmed. No local rise of temperature was found. There is a pyriform swelling measuring 3 into 2 centimeter in the left inguinal region above and medial to the pubic tubercle. Swelling has a smooth surface, well-defined margins, doughy in consistency, reducible with the last part of the swelling going in more easily than the first, and absent gurgling sound. It's not possible to get over the swelling and test isn't free and palpable. Deep ring occlusion test was done. Patient was examined in a standing position. Hernia was reduced. Deep inguinal ring was occluded by the thumb, and the patient was asked to cough. The DROT was positive. That is suggestive of indirect inguinal hernia. ZIEMAN'S test was done. The index place is placed over the deep inguinal ring, middle finger over the superficial inguinal ring, and ring finger over the saphenous opening. Impulse and coughing was felt on the index finger, which is again suggestive of indirect inguinal hernia. Invagination test was not done. Continuing the examination further, the opposite side was normal. Inguinal lymph nodes were normal by infection and palpation, and abdominal tone was good, but rectal examination was not done. Systemic examination was normal. So examination summary, patient was stable and had normal vitals. There was a 3 into 2 centimeter swelling in the left inguinal region above and medial to the pubic tubercle, pyriform in shape with smooth surface and well-defined margins, expansile on coughing and reducing on lying down. It was difficult to get over the swelling. There were no skin changes, visible pulsation, scarring, or dilated veins over the swelling. The deep ring occlusion test was positive and pulse was felt on the index finger on the ZIEMAN'S test. Opposite side was normal, and the examination is suggestive of indirect inguinal hernia without any complication. My provisional diagnosis would be left-sided uncomplicated incomplete indirect inguinal hernia containing omentum, which is reducible. And my differentials would be direct inguinal hernia, femoral hernia, saphenous femoral artery aneurysm, enlarged lymph nodes, and psoas abscess. Thank you.
So you may cross-question him now, sir.
Okay, right. So very good day, Ishan. Good presentation. Am I audible, Ishan?
Yes, sir. Thank you, sir.
Okay, right. Thank you. So it was a good presentation. It was a comprehensive, good presentation. Ishan, a few questions to ask you. On the first one is that why did you say that lump was a hernia at all?
So, because there was it was a gradual onset swelling in the inguinal region, and disappearing on lying down, and it was aggravated on walking, straining, and cycling. That is indicative of a relatively increased abdominal pressure. So most likely it was a hernia.
Okay, right. You said your differential diagnosis is a direct inguinal hernia. So,
Yes.
what are the tests that you did to differentiate a direct and an indirect?
So we did the deep ring occlusion test, which was positive. That means it's most probably a indirect inguinal hernia. And then I also did the ZIEMAN'S test, on which the impulse was felt on the index finger. That again is suggestive of indirect
Okay,
inguinal
right.
hernia.
Now, tell me clinically, you're going to be a clinician. Why do you need to distinguish between a direct and an indirect? Is it at all worth it to distinguish between a direct and an indirect hernia?
Sir, it so, 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 so one of the reasons could be that the indirect inguinal hernia is more prone to strangulation and other things, and the direct hernia usually doesn't really end up in strangulation. Other reason could be that direct hernias can be bilateral, and so if there is an occult hernia on the other side, we may not miss it. uh,
Okay,
but
right.
but but not the treatment wise, not really much of a difference, because we anyways have to provide because the treatment is surgery.
So that is exactly the point that I was coming to you. So that means that on the treatment point, the treatment remains the same, isn't it?
Yes, sir.
Okay. Can you tell me why is the indirect hernia more prone to develop a complication rather than a direct hernia?
So because the neck of indirect hernia is quite narrow, and thus it's more prone to compression and
Okay, right.
irreducibility.
So what are the common complications that happen in an inguinal hernia?
So, in an inguinal hernia, the common complications can be irreducibility, where the opening becomes narrow, that the hernia doesn't go back into the abdominal cavity. There can be incarceration, there can be strangulation, there can be vascular compromise, there can be bowel gangrene if the vascular compromise is.
Okay, I understand your point fully. Now, so in an OPD, your teacher tells you that this patient is to get prepared, or tell him what are his options, or you are the only doctor, your senior has gone out for a cup of coffee. So this patient or this patient's son asks you, doctor, what are my options of treatment? You said surgery is one option. Can you do without surgery? Because father is old now. What is the age of this gentleman? 52, I gather.
49.
49. Okay.
49.
So can we not do any surgery, or can you have some medicines for my father? What is your opinion on that?
So, like, I mean, this patient is 49. I mean, he's not uh, that old as well. But if the patient is
Come
old,
on. Acha. Okay, Ishan. He is a young guy. Okay, I understand that. Okay.
so I mean, if it's a really old guy and it's a small hernia which is not really causing any symptoms or pain to the patient, so we can continue with a conservative treatment as well. We can ask them to take care and do not do any like preventive measures, like don't do any straining or heavy exercise, something that would aggravate the hernia. And we can also prescribe a truss belt to reduce the hernia, so that just because it's
Okay.
let's say an old male and
So that means, say for example, the patient asks you, okay, doctor, I am 49 or say 50 years of age. My son is going to get married 1 year down. So can I wait for 1 year? I'm not asking you the technicalities of the operation. Operation will be done by a surgeon. Forget that. Say you are in your outpatient department the next week, and the patient asks you, doctor, can I have my operation deferred by 1 year? I understand that operation is important. Can I have it 1 year down?
yes, so most of the operation, because see, he's not presenting with any emergency, so most of the operations would be elective only. So if he wishes to wait for 1 year, it's his choice. We can always give him
now the
choice.
patient, okay, so now the patient smiles and says that I have 2 more sons and I want to operate or get it operated after 5 years. What is your opinion? Okay, so the patient says, the doctor, you told 1 year, so let me wait till 5 years. Okay, so what is your opinion on that?
Sir,
okay, right, good one. So you are doing absolutely nice. Now,
so
okay, wait, that's it. Now your teacher comes, the cup of coffee is finished, and he tells that it is a busy OPD. Before the operation, is he a smoker?
Yes, sir.
Hello?
Yes, sir.
So this gentleman is a smoker, isn't it? Okay.
Yes, sir.
Now, so he tells him that we are getting ready for the operation. He's smoking beeries. 12 pack years is his index, right? So we need to stop the beeries before the operation, right?
Yes.
So why do you think the patient needs to stop smoking before an operation?
So, one of the reason is because smoking is a direct is associated with uh, increased abdominal pressure leading to a hernia. Another reason is that smoking causes an increases in the blood pressure and because of the nicotine and etc. So before the surgery, we will always want the patient to be calm and sedated. So that's why we need to stop smoking so that we don't have any hemorrhage and etc. And
right.
the third one of the reason would be because obviously smoking is bad for health.
Okay, right. So you have hit on the point, right? That in the post-operative period, we are using stitches, isn't it? So sutures. So we don't need them to come off because the patient will have a chest problem. Very nice. So when does the patient need to stop smoking? I know that immediate is a better answer, but the patient is going to get operated. Your operation list is 3 months long. He gets a date of admission 3 months down. So when should he stop smoking? Immediately will be the best answer. But the patient says, the doctor, I cannot stop smoking. So when should he stop smoking?
So I don't know the exact time period.
Okay, the exact time period is usually 4 to 6 weeks before any anesthesia, because that makes the lungs okay. Now your teacher says that, okay, so by the time the patient is very motivated, he has listened to your history and examination, and he asks you, doctor, can you tell me some ways to quit smoking?
Okay.
Do you know of any ways to quit smoking?
So, so the primary, so if he's motivated, we can always offer him nicotine patch therapy for for the start. I mean, like we can slowly reduce the dose of nicotine so that he doesn't suffer from withdrawal. Then, we have like there is an option. I mean, he's not quite well off, but there's an option of e-cigarettes if he wants that.
Okay.
That reduces the risk of carcinogens and
okay, right. So that means that he is now in a smoking de-addiction clinic. So I think that your hospital has a smoking de-addiction clinic, and apart from nicotine patches, there are much more behavioral therapies, etc., that are used. Absolutely right. Now the patient asks you, doctor, okay, I know that your sir is very busy in the OPD. So can you tell me what are the common problems that happen after an hernia operation?
so after a hernia operation, the like there can be the sutures can give the immediate complications can be that the sutures give away. There can be a seroma formation, and then if it's because it's the abdominal tone is actually weak, so there can be and the tissue the skin may not align properly. Then there can be pain over the stitches, and if just in case during the surgery we have by chance cut any cutaneous nerves, there can be chronic pain as well. And then there is always the risk of incisional hernias.
Oh, they are not exactly called incisional hernia. They are called as recurrent inguinal hernias. Okay, so there is a chance of a recurrence in the hernia, and you need to tell the patient, very well said, that yes, after the operation you can have some pain, because there are nerves around that area. That's a sensitive part of the body. And number two, while I operate, there can be few nerves, and there is a chance that the hernia comes back. Absolutely rightly said. So these are all the points. The patient asks you, doctor, I'm a rickshaw puller. I think he's a rickshaw puller by occupation.
Yes.
Okay. So as now he asks you, or Mr. Lal asks you, that how soon can I join my work? Because rickshaw pulling is a heavy mechanical work.
Yes.
Particularly, say the passenger weighs 110 kilos. Okay, so he will take a long. So he asks you, when can I join my work?
So, ideally, he should wait for 3 to 4 months before joining, before actually doing any heavy work, because the scar
Okay,
tissue almost takes about 3 months to regain that strength.
okay, very nicely said. So the scar tissues are this. So these are more or the less. So you have said it very nicely. I'm very happy that you have understood that what are the basic points that any any doctor should understand about a hernia. And number two is that you have told more or the less all the points that everyone should know to tell about any patient of any discipline that you have a hernia. These are the points to be understood. Okay,
Thank
so
you.
good one, Ishan.
Thank you, sir. Thank you so much.
Okay, thank you.
Thank you, Ishan. Our next participant is Neha Rathodkar from BJ Government Medical College. Her topic of presentation is breast lump.
Okay, good afternoon, everyone. Uh, okay, should I start?
Yeah, please
Yes,
start, Neha. Good afternoon.
Good afternoon, sir. So myself Neha Rathodkar, and I'll be presenting a case on breast lump. So this is a postmenopausal 55-year-old woman who is homemaker by occupation, hailing from Somwarpet, Pune, belonging to class 3 according to the BG Prasad scale, was brought for the examination on 25th February 2020. She presented with chief complaints of lump in right breast since 1 year, discharge from nipple since 1 month. The lady was apparently all right 1 year back when she noticed a lump in her right breast over the upper outer quadrant while bathing. It was insidious in onset and gradually progressive in nature. Initially, the lump was smaller to begin with, 2 by 2 centimeters, and slowly progressing. But since 2 months, the swelling has been rapidly progressive and got the present size of 6 by 6 centimeter. The swelling was painless throughout, and it is associated with a nipple discharge, which is pink colored, non-foul smelling from a single duct since 1 month. There are no any complaints regarding the left breast. Also, she is suffering from loss of appetite and complaints of 6 to 7 kgs weight loss in the last month. There is no history of any fever, trauma, swelling in axilla, intake of OC pill, HRT or irradiation, no history of bone pain, jaundice, headache, respiratory distress, or any evidence of neurological deficit. She is a non-diabetic, non-hypertensive patient. There is no history of any chronic illnesses, medical or surgical intervention, biopsies, or allergy. Personal history, not significant. Menstrual history, menarche at 14 years, regular cycles, 4 to 5 days cycles, menopause at 50 years. She has got 3 children. All of them were adequately breastfed. So this is the pedigree chart of the family. This is the female who is suffering from breast cancer, and she has a maternal aunt who was also diagnosed with the breast cancer at the age of 50. There is no any history of other ovarian, colon, or prostate cancer in the family. So this is a 55-year-old postmenopausal lady complaining of a painless lump in the right breast since 1 year, which is associated with a nipple discharge since 1 month with clinically significant weight loss since 6 months, and also has a positive family history of malignancy in maternal aunt, no complaints of any swelling in axilla and neck region. General physical examination, examined in sitting position with both the hands on the side, adequate daylight, and proper informed consent. So her BMI was 21, pulse rate 68 per minute. BP was 124 by 72 mm of Hg in the right arm. Respiratory rate 18 cycles per minute. No pallor, icterus, cyanosis, edema, or clubbing. So examination of breast inspections. She was inspected in sitting position by arms by her side, raising arms above the head, bending forward position, lying posture, and hands on the hip. Left breast, it is globular in shape. Skin appears normal. There are no any dilated veins, scars, ulcers, or sinuses. Nipple areolar complex appears normal. Right breast, it is slightly displaced laterally. Size and shape is shrunken as compared to the other breast. There is visible fullness behind the nipple areolar complex over the upper outer and upper inner quadrant. Skin, reddish discoloration is there. Dimpling and puckering seen. For the orange appearance of right breast is seen. On raising the arms, the dimpling over the breast appears to be prominent. Nipple, it is displaced upwards and outwards and deviated to right, retracted with no discharge. Areola dark, edema and redness present over the perioreolar region. No visible swelling on inspection of axilla and supraclavicular fossa. On bending, the right breast fell forward less than the left and nipple retraction was noted. Inspection, there is no edema of any of the arm. Chest does not have any nodules or ulceration. Movement of the shoulder joint was in full range and painless. On palpation, no any findings in the left breast. Right breast was warmer as compared to left, not non-tender. There is a single lump which is palpable behind the nipple areolar complex in the upper outer and upper inner quadrant. The size is 6 by 6 centimeters. Margins are well defined, irregular. The surface is uneven. Consistency is uniformly hard, and it is fixed to breast tissue and the overlying skin, fixed to the chest wall and pectoralis major muscle. Nipple areolar complex, lump is fixed to the nipple, retraction is noted, non-foul smelling serous discharge from the nipple on compressing it. Areola is thickened with multiple small nodules. Examination of axilla and neck, no lymph nodes were palpable in both axilla and neck. Systemic examination, CNS, she's conscious and oriented. Chest, there are no any added sound. Per abdomen, soft, no organomegaly, no evidence of free fluid in the abdomen. Per vaginal, per rectal, normal. Examination of spine is normal and there are no any restricted movements. Provisional diagnosis, this is a 56-year-old postmenopausal lady with a lump in upper outer and upper inner quadrant of right breast, also involving the nipple areolar complex, and is most likely a case of carcinoma breast, stage clinically T4C N0M0, that is, it belongs to stage 3B. Thank you.
Okay. Okay. Well, very nicely presented. Okay.
Thank you, sir.
So Neha, I'm really impressed because even my postgraduates do not present such comprehensive as you have. So very nicely presented.
Thank
Okay.
you, sir.
There are a very quick set of questions. Number one is that, so you diagnosed this 55-year-old postmenopausal lady
Yes.
to have a malignancy in the breast, isn't it? Okay. Why
Yes.
did you feel that lump was a malignant lump?
So basically, from the history points, this is a 55-year-old, that is elderly postmenopausal lady, and she has presented with a rapidly progressive lump. And also there is a nipple discharge, which she told me it was pink. So most probably it was a bloody discharge. And then there is also a family history of maternal aunt having breast carcinoma. And then on examination, I could find there was a hard lump with the irregular margins. So these were my findings.
Okay, so these are the points that you made
Yes.
more in favor of this one.
Breast
Now,
carcinoma.
tell me that if these findings were observed in a lady, say her daughter is 28 years age,
Yes.
then her daughter came with the same set of findings. What would have been your thoughts?
So, of course, if there is a family history, there is always a chance that she could also be suffering from a breast cancer. But I would
Okay.
also keep the other benign lesions of breast into my mind because she is a young lady presenting. So, fibroadenoma could be one of my differential diagnosis.
Okay. Can you know of any other malignancies in the breast apart from the epithelial malignancies? So,
Yes, so sarcoma can be there. Cystosarcoma phylloids can be there, which can
excellent.
be
So,
malignant.
okay, so cystosarcoma could be a differential diagnosis at a younger age group,
Yes.
so particularly between the age of 20 to the age of 50. Cystosarcoma phyllodes always does come, but you have presented it very nicely. So 55-year-old lady presents with a breast lump. Now, they had important points are the patient after the examination. So you have presented the case in front of me. Now, you are there in the outpatient department with your teacher, and your teacher had an important phone call to take. The patient is asking you, doctor, what is your opinion on the lump? Because your set told that okay, so have a chat with the patient while I come back. So the patient asks you, I can ask you on behalf of, or the daughter asks you, doctor, what do you think is my mother's disease? So what is your comment on that?
So basically, firstly, I'll examine the patient and then I'll give my opinion.
No, you have done that. All the examination
Okay.
is done. So your clinical diagnosis is a T4C N2M0. You know
Yes.
that. Now to the patient or the patient's relative, what are your statements that you are going to make? Because they are going to ask you, "Hey, doc, what do you think is your diagnosis?"
So I'll first brief her about like the malignancy. She's suffering from some malignancy. I'll tell
Okay.
her that, and what her maternal aunt had suffered. This is something same kind of that thing I would tell her, and
Okay.
it has to be examined further, and she has to be admitted there. Is what I would tell her.
Okay. Right enough. So now the daughter is a little bit well read. So she is a school teacher. The daughter
Okay.
asks you, "Doctor, okay, so I think that so you are telling that this is a malignancy. Okay, very good that you did not use the cancer word. I really appreciated that. So don't use the cancer word in front of a patient. Patients get scared. Use that your mother had a tumor in the breast. Probably it is a malignant tumor, and I
Yeah.
need to do a couple of tests to confirm my findings. So what are the tests that you will do that are going to confirm that this is a cancer?"
So basically, I would go with the triple assessment that has got 99.9% specificity. So firstly, in that is the clinical examination. Then I would go with scanning as she's a 55-year-old lady. So I would go with a mammogram. Then after that, I would go with a core needle biopsy, which would confirm my diagnosis.
Okay, really impressed. Now, your mammogram, so the patient has come to you with a mammogram and a condylom. Which one is done first, the mammogram or the core?
Yes, mammogram is done first, sir.
Okay, why not the core needle biopsy, then the mammogram?
Sir, because it would help us to localize the breast lump, and then also there can be microcalcification, or there can be a occult malignancy also there. Like other lump can also be there, which could not I could not palpate, or the clinician could not palpate. So for that,
Mhm.
I would first go with the mammography. Like I would get to know
No,
if
say
there
for
is any
example,
another lump. Yes,
right now again, Neha, consider the point. This patient has a big lump, isn't it?
yes,
So there is no question about having an occult or something that you could not palpate. The lump is so big that it is a T4C. Now,
yes,
so in this patient, why not do a core needle biopsy today? And then, say for example, the patient is not so much economically strong. The patient comes to a hospital that has a huge volume of patients, and they plan in doing a biopsy today. 1 week later, she gets a date for a mammogram. So why can't we do that? Let us do the biopsy today, isn't it? So that will be much more easier thing.
No, so because of that biopsy, we may infiltrate the malignant cells into some other site, maybe where the
Okay.
cancer has not been spread yet. So,
Uh, See, the main answer for that is that when you do a biopsy, the main point is that all biopsies are associated with blood, isn't it? So whenever
yes,
you prick some tissue, it will produce blood. Now, blood contains calcium. And as you very rightly said that in a mammogram, what is picked up is calcification.
microcalcifications, yes.
So that biopsy tract will be interpreted that even if the patient had a fibroadenoma, you are going to interpret after a biopsy that to be a cancer sometimes.
Okay,
So that is
yes,
the
sir.
reason you never do a biopsy before a diagnosis. You do it
Done.
after the mammography and then you do a core needle biopsy. Okay.
Okay,
Now,
thank
so you attain a diagnosis that this is a carcinoma breast. So the patient and the relative comes to you, the doctor. Your diagnosis has been, you are a good clinician. The biopsy reports has come to be a cancer. Now, they are going to ask you, your teacher is busy with another patient. They are going to ask you a very straightforward question. What is the stage of the disease?
you. Okay, so I would try to make them understand that is, they have come, like it's a locally advanced cancer now.
Mm-hmm.
If they know that it's a cancer, then it's a locally advanced cancer and it needs to be treated early as possible so that it does not progress to some other stage. So
Mm-hmm.
you're well within the time, and I would the clinician will tell you more. I would tell that only, sir.
Okay. So the patient's daughter now asks you, the doctor, how can you be so sure that the cancer is only limited to the breast? How do you know that the tumor has not spread, say, to the brain, to the liver, etc.? How do you know that?
So basically, as I know this is a locally advanced cancer, I would like to go with the investigations only. So of course, the clinician will also tell them to get a bone scan, then CT chest and CT abdomen. Then only we can comment upon that. But also based on the symptoms, she is not presenting with any such symptoms. As I took the negative history, there were
Okay.
no any symptoms of bone pain or any other respiratory complaints or abdominal complaints.
Right, absolutely right. Which is the most common site that a breast cancer has a distant metastasis to?
Most probably, like lumbar vertebra is the most common site, followed by femur and then thoracic vertebrae.
Okay, why do you think lumbar vertebra is so favorite?
Um, because due to retrograde flow through the posterior intercostal vessels and then through the Batson plexus, it goes there.
Okay, right enough. And please remember that the maximum amount of blood circulation occurs in the most flexible area of the spine, that is T10 to L1. So they are the
Okay.
most perfusion part of the spine, and hence any hematogenous metastatic things are going to go to that area. Okay, right.
Okay.
So now, so the oncologist is going to go for a couple of tests. Now the patient says that, okay, doctor, you are a very good clinician. What is my chance of survival? Because
Um,
see, all cancer patients are going to ask you that. You said it is a locally advanced. So what is the chance of survival? Say 5 years, 10 years down
so
the line.
yes, 5-year survival rate is about 50% in these cases. I don't know, maybe I should tell that to the patient or not, but
Okay.
this is what I know.
So very good. So tell them honestly that, sir, I need to look up the books, but to the best of my knowledge, this is that. So I'll definitely ask the oncologist, or I can see into that. Now, good one. I'm really very impressed that you have a good knowledge about that. Now the daughter asks you that, you see, mom had a cancer and my aunt had a cancer. So doctor, what is the chance that I have a cancer?
Uh, so these hereditary cancers, there is always a chance, about 5% chances there. So I would tell her there's a chance, but if she undergoes annually like breast examination, or I would tell her that she should undergo self breast examination.
Mm-hmm.
And maybe as it's a familial case, MRI would be the investigation of choice in that case.
Okay, okay, okay.
Uh,
Just a minute. Before we stamp it as a hereditary, familial, and all of these things,
yes.
okay, how can you be so sure that this is a patient with a hereditary, say,
No,
a
sir, not
genetic thing?
hereditary, familial, sir.
Oh, oh, so these are different terms, isn't it?
Yes,
What is the
yes.
difference between hereditary and familial?
So hereditary are those cancers, those are mostly a autosomal dominant trait, and they may present with some other cancers also in that family, like ovarian, prostate, or colon cancer. And mostly they appear at a younger age and are present bilaterally. Those are
Mm-hmm.
most commonly the genetic cancers, and they account only 5% of the total cancers. Mostly the cancers are sporadic, 70%, 25% are familial, as in this case, just one relative is having this cancer.
Okay, so the bottom line is that, now what is the difference between hereditary and familial then? The simple bottom line is that familial means you have not established any genes.
Yes, there's
It
no
goes in
connection.
general.
Yeah,
There is no, there is a connection,
yeah,
but
but
till to
not
this
as
date,
confirmed as.
you have not identified the gene, isn't it? In a
Yes,
hereditary, you have identified the gene. So, for example, BRCA1, BRCA2, and those genes. That is something called as a hereditary. Now, so
yes.
this lady asks you, "Okay, doctor, so as you have said, self breast examination, clinical breast examinations is that. So, can I have something more better? I need a foolproof understanding that I am going to have cancer, I am not going to have a cancer.
So
Do you know
basically,
of any? She's
yeah.
a school teacher, so she's educated.
So she should go for the genetic analysis. Like if she has BRCA1 or BRCA2 genes, then it is for sure she's gonna have that
Okay,
cancer.
but that is a costly thing, isn't it? In India, it is costly. So, do you know of any models that can predict that her
Yes,
chance of getting a cancer?
yes, yes. There's Claus model and Gale model. The cloth model, it takes into account the age of a menarche, the age at which she has
Okay,
the
right.
first
So
child. Yeah.
that means that now this lady, say on a clause model, it is seen that by the age of 30, she has a 92% risk of getting a breast cancer. Okay, so the genetic guy tells you that, he gives you a report on the software. Now, as I said, this lady is very educated, so she shows you on her Android phone that, see doctor, I calculated the risk, it is 92% by the age of 30. So what should I do now? I don't have a cancer now, but this predictor is like an astrology prediction. Okay, so it predicts that 92% chance. What should I do now?
She should go with clinical examination and MRI only, I feel.
Okay, good one. Very good answer, sir. So you should think that MRI is a good screening tool. Do you know of any other better investigative or any models other than a Gale and a clause? Okay. Have you heard about something called as a BRCA Pro? Because this is all about, okay, this is about BRCA testing and then a Pro. So good one. So you have said exactly the things, right? The last of the questions is, the patient says, the doctor, what kind of operation? Because that is, the operation will be done by the surgeon. What is the nature of the operation that the surgeon is going to do?
So basically, in my case, it was a locally advanced breast cancer which had spread to the chest wall as well as the skin. So at this stage, it is inoperable.
Okay.
She should go with neoadjuvant chemotherapy. After that, if it gets converted from inoperable to operable, then we can think of a surgery.
Okay, excellent on that. Okay, so that means you are giving chemotherapy before the operation. Very good. So I'm impressed on that. Now, what are the common, or what is the operation? Say the tumor shrinks down. It is 10 centimeter, now it is 2 centimeter. So what is the operation that the surgeon will usually be planning in that case?
It would be modified radical mastectomy, sir.
Okay, so it will be a form of a mastectomy. And what about the regional spread of the disease?
So as this disease is, it has not spread to the axillary lymph nodes yet clinically.
So do you think that should be left alone, or do you prophylactically remove those nodes?
Yes, sir. In modified radical mastectomy, we remove the level 1, level 2 lymph nodes. At least 10 lymph nodes are removed.
Right. So that is a therapeutic procedure, isn't it? So this is the locally advanced. There is no question of staging the axilla by other non-sentinel, etc. So you always have to remove that. Okay. So right. So I am impressed. All questions on my end are done. Thank you.
Thank you, sir. Thank you so much. It was a great opportunity. Thank you.
Okay. Thank you, Neha.
Thank you, Neha Rathorkar. The last participant for this event is Anjali Rajkumar from ZIEMAN'S. Her topic of presentation is obstructive jaundice.
Good afternoon, sir. Can I share my screen?
Yeah, please start.
Is my screen visible, sir?
Yeah, your screen is visible. Please.
Good afternoon, sir. I'm Anjali Rajkumar from ZIEMAN'S. Today, I'll be presenting a case of obstructive jaundice. So, 63-year-old male, Mr. Ramamurthy, educated up to 10th standard and working as an automobile mechanic, hailing from Villupuram and belonging to lower middle class according to modified Bija Prasad scale, presented with the chief complaints of yellowish discoloration of eyes for 4 months, generalized itching for 1 month, and pain right upper abdomen for 2 weeks. History of present illness. The patient was apparently asymptomatic 4 months ago when he noticed yellowish discoloration of eyes in the mirror. The discoloration was insidious in onset, gradually progressive and deepening over the first 2 months, followed by diminution over the next 1 month and deepening again for the last 1 month. This was associated with high colored urine, color increasing progressively, and clay colored stools for the same duration. The patient also complained of generalized itching for 1 month, which was progressive in nature and affected sleep. He complained of right upper abdominal pain since 2 weeks, which brought him to the hospital, which was insidious in onset, dull aching in character, continuous type, moderate to severe, with radiation to back, aggravated on lying down and relieved by leaning forward with no association with food intake. There's a history of significant loss of weight of 10 kgs in the last 2 months and a history of loss of appetite for the past 1 month. There's no history of any vomiting, abdominal distension, blood in vomitus, or passage of dark, tarry, sticky, foul-smelling stool. There's no history of episodes of any fevers with chills and rigors, no history of lump or abdomen, no history of breathlessness, hemoptysis, or bone pain, not a known case of diabetes or hypertension, and there's no history of any drug intake. Past history, there's no previous history of jaundice, blood transfusion, or surgery for the patient. There's no history of any tuberculosis or asthma in the past, and no prior history of hospital admissions too. Coming to personal history, the patient is having a mixed diet, reduced appetite. The patient is a chronic consumer of alcohol. He consumes 3 days in a week, 180 ml of brandy per day for past 40 years. The patient is also a chronic smoker with 20 pack years. The sleep was affected due to itching. There is no recent alteration in bladder habits. Stools are clay colored. Coming to family history, the patient has no family history of any malignancies such as pancreas, breast, or GI, or any other malignancies, and there's no history of similar complaints in the family in the past too. Coming to treatment history, the patient presented to JIPMA with the complaints of for which blood investigations, ultrasound scan, and CT scan were done. Coming to physical examination, the patient is conscious, oriented, and cooperative, and he is moderately built and poorly nourished with a BMI of 19 kg per meter square and ECOG score of 1. There's no signs of dehydration. Icterus was present. There's no pallor, cyanosis, clubbing, lymphadenopathy, or pedal edema. There are no signs of liver cell failure. Scratch marks were present all over the abdomen and thighs. Coming to vitals, the patient was afebrile with a pulse rate of 62 beats per minute, regular in rhythm, normal in volume and character, no radioradial or radiofemoral delay, and was measured in the right radial artery. The blood pressure was 130/80 millimeters of mercury, measured on the right arm in the sitting position, and the respiratory rate was 16 per minute. Abdominal examination. On inspection, the abdomen was flat, umbilicus in the midline, pushed downwards and inverted. Corresponding quadrants were moving equally with respiration. There's no visible lump, peristalsis, scars, or dilated veins, no left supraclavicular fullness. On palpation, the liver is palpable 5 centimeters below the right costal margin at the mid-clavicular line, soft, non-tender, smooth surface, rounded margins, firm in consistency. A soft globular non-tender lump palpable in the right hypochondrium with a smooth surface and well-defined borders which moves with respiration suggestive of gallbladder. On percussion, the liver span was found to be 20 centimeters at the right midclavicular line. Shifting dullness was absent. Drop space was resonant. On auscultation, normal bowel sounds were heard. Other systems were examined and found to be normal. So, summary of my case, a 63-year-old gentleman presented with progressive jaundice, high-colored urine and clay-colored stools for the past 4 months, associated with generalized itching for 1 month, and associated right upper abdominal pain for 2 weeks, also had a significant loss of weight and loss of appetite for a month. On examination, he was found to have icterus, hepatomegaly, and a palpable gallbladder. My provisional diagnosis for the case is this is probably a case of obstructive jaundice of chronic onset due to periampullary carcinoma with no evidence of metastasis.
Okay.
So my differentials for the case will be, it can be a carcinoma gallbladder with metastasis to porta hepatis, or it can be a cholangiocarcinoma involving the bile duct, or it can be a lymph node mass in the porta causing the biliary obstruction, which was actually a secondary to metastatic lymphoma or tuberculosis, or it can be chronic pancreatitis, bile duct stricture, or choledocholithiasis. Investigations, I would like to...
Let us stop at this point. Okay.
Okay, sir.
Very good presentation, Anjali. Really.
Thank you.
Impressed. I'm really impressed by all the 3 presentations. Even my residents should be seeing these presentations. I'm really very impressed. Anjali, just a few points to ask quickly. You said that the patient has jaundice, isn't it?
Yes, sir.
You said that the patient has jaundice. Why did you feel that the patient has jaundice? What are the findings that made you say that the patient has jaundice?
Yes, sir. So patient came with yellowish discoloration of eyes, with yellowish discoloration of urine, clay-colored stools, and there was pruritus also. So all these are classically of obstructive jaundice. Uh,
Okay,
and
wait.
yes, sir.
Let us go one by one. Okay,
Yes,
so
sir.
number one is that the patient had a yellow discoloration of eyes, he had
Yes,
yellow
sir.
discoloration or a high colored urine, and that is
Yes,
the
sir.
point that is in favor of a jaundice, right?
Yes,
Okay.
sir.
Now, so jaundice, as you know, as we all know, is a state where there is more bilirubin in the blood, isn't it? Okay.
Yes, sir.
Now, where is bilirubin made in the human body, or where is bilirubin manufactured in the human body?
So bilirubin is manufactured in the liver.
Okay, in an adult.
Yes, sir. Yes, sir.
Okay. Any other site? Come on. Any other site where bilirubin is manufactured?
Yes, sir. In the bone marrow, due to breakdown of red blood cells.
Okay. Any other part of the reticuloendothelial system? Where are red blood cells killed in the human body?
Yes, sir. In children, spleen is also a production, but adults only breakdown happens in the spleen.
Okay. So both. So the whole of reticuloendothelial system. Remember that
Yes.
that can be the liver, the spleen, etc. Particularly
Yes.
remember that in a case of splenomegaly,
Yes,
the
sir.
spleen takes up a big role in killing the RBCs, and then
RBCs.
hemoglobin can get
Yes, sir.
converted into bilirubin, right?
Yes,
So now
sir.
you said that the patient is suffering from obstructive jaundice, isn't it?
Yes, sir.
Okay. So why not hemolytic or hepatic jaundice?
So the patient, if a patient comes with yellowish discoloration, we can just confirm that it's a jaundice, which can be medical jaundice or surgical. But this patient is additionally having clay-colored stools and high-colored urine with a rapid increase in the jaundice, and there is pruritus also. All these can be occur only by conjugated bilirubin, and so this is a case of obstructive jaundice, sir, and not a medical
Okay.
jaundice.
Agreed. Absolutely perfect. Now, say for example, now in India, say for example, this was a viral hepatitis. Say
Yes, sir.
hepatitis A or hepatitis G, or say for example, the gentleman takes a lot of alcohol. So it is alcohol-induced hepatitis. So how do you
Yes.
differentiate between a hepatitis from an obstructive jaundice?
Yes, sir. Sir, in history, I've asked the patient for any recent history of injection from any local hospitals or any tattooing, etc. These are the cases by which he can contract a viral hepatitis.
Okay.
And
Anything more?
coming to examination, in so viral hepatitis patient will have hepatocellular dysfunction, and hence he can't
Okay.
present with this much rapidity in the progression of jaundice won't take place, and there is
No, say
no
for
obstruction as
example,
such. So yes, sir.
no, I know that this is no obstruction, but
Yes,
the
sir.
important question is, say for example, if you think about viral hepatitis, isn't it? So what
Yes,
happens
sir.
is that the hepatocytes, when they die, but before dying, they get ballooned up. They look like
Oh,
balloons.
yes,
And
yes, sir.
what it does is that those ballooned up hepatocytes or edematous hepatocytes, they block the bile canaliculi.
Yes, sir.
The problem is that, and that is the same pathology in an alcohol-induced hepatitis as well. Those damaged hepatocytes are going to block those biliary canaliculi. So that means there is a obstruction, but that obstruction is at a microscopic level. Okay,
Yes,
so
sir.
that will produce also the same features, isn't it? So that is going to produce again the urine to be high colored because there is more conjugated bilirubin in the blood. So my
Yes,
question
sir.
is, how do you differentiate, or what exactly is a surgical obstructive jaundice? That means a surgeon is involved. Versus there is nothing called
Yes.
medical obstructive jaundice, but what is a surgical
Uh,
obstructive jaundice?
uh,
That means the obstruction is of such a
has to
nature
be. Yes,
that
that we have to
you
surgically intervene to resolve the
ah
cause, rather than if a viral, we can just give
exactly.
medications.
Exactly. So that is the point, isn't it? So my
Yes,
question
sir.
is, doctor, how do you differentiate that viral hepatitis from a surgical obstructive jaundice? Because see, the patient will get admitted in different ward, isn't it? Medical
Yes, sir.
jaundice will get admitted in a medicine ward, surgical in a
Yes, sir.
surgical ward. So how do you
Yes, sir.
differentiate between that?
So that at the investigation level
So number
only
one
we
is
can.
that, as you told, that history.
Yes,
No,
sir.
before the investigation, clinically.
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 So
Which one will have
clinically,
a palpable liver?
so palpable liver will be present only in
Which one will have
obstructive
a
jaundice.
palpable liver?
Only in obstructive jaundice, sir. Because
No, the
hepatitis
medical,
takes.
even don't you think a viral?
Sir, it takes sufficient time to
Okay, hepatitis you also
become.
get a palpable liver, but
It,
ah,
sir,
very
gallbladder
nice.
is
So
palpable
that
in a
means what
case.
happens with that is that it is a tender hepatomegaly.
Yes, sir.
Yes. So gallbladder is only palpable in what kind of jaundice? It is a
Obstructive
surgical
jaundice, sir.
obstructive jaundice.
Surgical.
Very nicely
Yes.
said. Why do you think is the gallbladder palpable in a case of surgical obstructive jaundice?
According to Courvoisier's law, if the gallbladder is
Okay.
palpable in case of a jaundiced patient, then it is probably due to malignant causes, and we can rule out stone formation because there'll be fibrosis of the gallbladder. So this points towards the malignancy present in the patient, which I have listed as the
Okay. So
differential
that means by the
diagnosis, sir.
Courvoisier's law, so a palpable
Yes, sir.
gallbladder goes more in favor of a malignancy.
Yes, sir.
Absolutely right. Now, so if this is this one, so you have said that there is a periampullary carcinoma which is
Yes, sir.
producing a obstructive jaundice. What do you
Yes, sir.
exactly mean by the term periampullary carcinoma?
So actually, periampullary carcinoma is a wide term which consists of all the malignant tumors within 2 centimeter from ampulla. This includes the distal common bile duct or this within 2 centimeters of the head of pancreas, the duodenum within 2 centimeter from ampulla or the ampulla of Vater carcinoma. But sir, in my patient, we can see that the jaundice is diminishing and then coming up. So this is like a characteristically of the carcinoma of ampulla of Vater, but most commonly we see carcinoma of pancreas only. But in such a case, jaundice will be progressively increasing only. And hence I came to this conclusion that it is probably a ampulla of Vater, sir.
Okay, now on the parallel one, as a very good explanation, say there is a stone in the bile duct. The
Yes, sir.
stone gets tightly impacted, jaundice increases, the stone gets dislodged, and the jaundice
Yes, sir.
decreases. So
Yes,
that
sir.
will also produce a decrease and increase in jaundice. So why don't
Yes,
you
sir.
feel this is due to a stone in the bile duct?
Yes, sir. Because primarily the gallbladder is palpable, and other features stone formation is always benign, sir. The patient is elderly, and the patient is having significant weight loss and loss of appetite, and the progression of disease has been rapid. Also, he doesn't have any previous history of chronic cholecystitis episodes. So this is the first episode also. And the patient's
Okay.
jaundice in a stone will be resolved completely. It is intermittent, but here it is remittent, sir.
Okay, I understand that. So that is the reason you are going more in favor of a malignancy than in favor of a benign disease. I really like
Yes.
it. Now, this patient tells you the doctor for the last 7 days, every time I do brushing, I feel that there is a bleeding from the gums.
Yes, sir.
What is the problem that you think is happening with the patient?
So this patient is due to obstructive jaundice. There is fat malabsorption. So with the vitamin A, D, E, K are not absorbed. So vitamin K dependent coagulation factors are not being synthesized in the liver, and hence patient will have a prolonged bleeding and floating time, and hence he is having the bleeding gums while brushing teeth.
Okay. Now, so done. So your teacher or the surgeon sees that, and the surgeon does a lot of tests, and he lands up with finding exactly the finding that you had. That was a pancreatic head tumor, and the
Yes, sir.
pancreatic head tumor is compressing the bile duct. Okay, very nice. So
Yes, yes.
the patient comes to you the next day with a CT scan report that, okay, doctor, so the pancreatic head tumor is diagnosed.
Yes, sir.
Now, by the time your sir or your surgeon is seeing another patient, the patient and the patient relatives ask you, doctor, what do you think is the outcome about these type of tumors in that?
So Actually, in reality, we know that even after corrective surgery, the patient's median survival is only 3% in head of pancreas, while in periampullary, it can go till 30%. But if we reveal as such to the patient, it will be very shocking. So we can tell him that the curative surgery will clear him of all his problems and symptoms, but his life expectancy is at stake. So he will be asked to take the medicines, but I can't give a false hope that he's completely cured and he can live a normal life, because he can sue me in the future. So I would prefer telling that.
Right. Prefer telling the truth, but definitely you need to tell the truth
No,
as
yes, sir.
exactly. So you need to break the news that yes, so this
Yes,
is not a
sir.
very good cancer to have had. Now
Yes,
the CT scan also tells you that there are metastasis. That means the tumor has spread away from the pancreas and has gone to the liver.
Yes, sir.
So now the surgeon, your surgeon is busy. The patient relatives ask you, so doctor, we have read it on the internet that father is not going to live for a long time.
Yes,
Okay,
sir.
so they have consulted some surgeons. So, but they are thinking about that this gum bleeding is getting problematic, and so they are asking you, can you do something for the gum bleeding? And my
Yes,
father
sir.
is having much problems of jaundice. So do you know how to take care of the jaundice? They know that their
Yes,
father is
sir.
going to live for 6 months.
Yes, sir. So first we'll treat the gum bleeds, because this is also a patient is not fit for surgery. So first we'll give injection vitamin K for 5 to 7 days. But then when we observe if the patient is still having the problem, means there is a hepatocellular dysfunction. So even if we give vitamin K, the hepatocytes are not functioning properly to synthesize the clotting factor. So then we have to go for a fresh frozen plasma blood transfusion. And then after that we can tell the patient that we cannot correct the patient's problem, but we can have a palliation, that is all his current complaints and morbidity can be reduced. So for that I would choose to do a triple bypass surgery for the patient. So my aim is to relieve the jaundice, to relieve the pain,
Okay,
and to
doctor,
relieve any
very
gastric
nice.
outlet obstruction. Yes, sir.
Right. So rather than doing an open operation, or rather than doing an operation, say the patient's relative tells you, doctor, we know that father is not going to live more than 6 months. Okay.
Yes,
So
sir.
do you
Yes,
have
sir.
any option of not doing an
Yes,
operation but
sir.
relieving the jaundice?
Yes, sir. Transhepatic cholangiography is a method through which, without operating, we can relieve the jaundice in the patient, sir.
Transhepatic. Okay. So any other better? So any endoscopic intervention that you know of?
Sir, and yes, sir. ERCP we can do, ERCP and stenting.
Okay, right. And
Yes,
as
sir.
you know, pancreatic cancers are exquisitely, they are one among the most painful cancers in the human body. So the
Yes, sir.
patient is requesting, can you give some interventions so
Yes,
that
sir.
father's pain is reduced? Do you know of any
Yes, sir.
drugs that are helpful in cancer pain?
Yes, sir. So,
Any
is a
painkillers or
NSAIDs,
analgesics?
so NSAIDs like NSAIDs won't affect. We'll try with NSAIDs first, like indomethacin, but patient might still have pain. So I'll
Will you
prefer
use
to
indomethacin in
go.
this patient? Think over, doctor. Will you use indomethacin?
No, sir.
Patient is elderly, patient
SAS,
has a coagulation problem
yes, sir.
already. So we'll use indomethacin. Already his
Yes,
stomach will be very badly eroded. So do you know
yes,
of
sir.
any other painkillers?
Yes, sir. We can do a celiac blockade with absolute alcohol or bepivacaine
Okay, so that is the
or
last step.
morphine. Yes, sir.
Ah, you can use tablet morphine or
Morphine.
buprenorphine. Okay,
Yes.
so that can be
Okay.
done. Okay, so thank you for your
Yes, sir.
presentation. It was really nice hearing from you.
Thank you, sir.
So, okay, so very good
Thank you,
presentation,
sir.
all of you. Thank you.
Thank you, sir. Thank you.
Thank you, all the participants, and thank you so much, sir. We are extremely overwhelmed of your presence at SAMSACON 2.0. Firstly, I would like to mention this. And next, sir, looking to your popularity, there are many final year and fourth year students watching you live on YouTube. I would like to say that they are actually worried as they didn't have any clinical exposure this year. And we would like you to give them some advice regarding how to prepare for upcoming professional examinations, sir.
Well, thank you very much. Number one is that all these three presentations that were made, I am really impressed because even my residents who do regular case presentations, some So they are even not so much accurate as all the three of you have been. Now, for all the students, because their clinical teaching has been grossly hampered, see, one among the best platforms of teaching now is definitely there is no replacement for a bedside clinical teaching. This is the first and the most important word probably from a clinician to another would-be clinician. That definitely you can read books, but definitely seeing one patient is more than reading 100 books. So until and unless the conditions become conducive so that you can see patients in future, you have to abide by reading books and gaining your experience. Probably one among the best ways is to present the cases like this, like the platform that you have done, is that you can hold around regular, say, virtual case presentations. You can have topic-wise presentations. So, for example, someone presented a beautiful case on an obstructive jaundice, someone with a breast lump. So, if you can have some consortium of case presentations over a day or two, say jaundice with around 3 cases, and then a teacher along with the student can have a discussion on exactly what will be the differential diagnosis and that. Number two is that technology has made things very. Now there is another side of a virtual teaching is that technology for everyone, particularly with easier availability of online videos. Say for example, you can have the examination methods in YouTube, but yes, you can have those curated videos, and those curated videos can be discussed. Or what you can have is that for teaching purposes and for encouraging teaching, you can hold a competition amongst students, particularly final year students, on various clinical methods. Like someone was talking about deep ring occlusion test as being positive. Like, yes, it is called as positive, absolutely right. But again, some terminologies are a bit confusing, like having a positive result in a test, having a negative result. So rather than say it as a positive, probably a better way of talking about it is that on occlusion of the deep ring in a hernia, the bulge was seen medial to the deep ring, suggestive that it is a direct hernia. So that is another way of presenting. It is not that the positive and negative are wrong. There is a better way of presenting. So that is the only message. So I think that in this virtual world of teaching, so more amount of virtual case presentations are to be encouraged. The more students present, rather than read and get bored and they feel that okay, so we are not learning anything. Participating in a discussion forum like this probably is one among the best ways to read. Okay.
Thank you so much, sir. It was an absolute delight to witness all the cases. And even I feel in the final year, I was not so good at presenting at this level. And with your insights, I'm sure all the participants, all the viewers who are watching us live and who would watch us later would gain more and more insight. And sir, we would love to have you again with us. And as you said, more of such clinical consortiums. So thank you so much once again, sir, on behalf of SAMSA.
Okay, thank you very much. And
yes, sir.
And all the 3 participants, if they're still in the group, you all did very well, and really I'm impressed, because in the morning I was taking a class for my postgraduates, again more or less on the 2 of the same topics, and believe me, you guys did really you guys excelled more than 70% than my postgraduates. So good going, and best of luck for life for everyone. Okay, right. Thank you everyone. Bye.
Thank you, sir. The results will be out in the final valedictory ceremony, which will be held today at 7 p.m.
Right. Thank you then. So I'll be sending you the results.
Sure, sir.
Bye.
Thank you.
Thank you.
Good day, sir.